This patient maculopapular rash involving the trunk and extremities and soles is most likely due to secondary syphilis. Primary syphilis typically causes a painless genital chancre inoculation site that can often go unnoticed. Untreated primary syphilis progress within weeks to months to secondary syphilis, which typically causes diffuse maculopapular rash due to widespread circulation of the Treponema pallidum. The rash usually begins along the skin cleavage lines of the trunk and extends to the extremities, including the palms and the soles. Because Treponema pallidum cross the placenta, the patients are at risk of obstetric complications, including fetal growth restriction, as possibly demonstrated by patients lagging fundal height 28 cm at 31 weeks of gestation. Other complications include congenital infection and possible intrauterine fetal demise. Therefore, all pregnant patients are screened for syphilis at the initial prenatal visit. Repeat third trimester screening is indicated in patients with risk factor HIV or limited no prenatal care, such as this patient. Those testing positive are treated with intramuscular penicillin G or benzathine penicillin. Okay, look at the picture of the pityriasis rosea, ovoid dark scaly patches, Christmas tree pattern. Okay, polymorphic eruption of the pregnancy. Okay, pruritic arterial papule. Sorry. Yes, pityriasis does not involve the pumps in the soul. And look at the tinea versatile color, hypopigmented, hyperpigmented patches, hypo and hyperpigmented. Okay, next. Is it retained? So absorption may not retain. May not be. Okay, you choose. So this patient with malodorous tan brown vaginal discharge and a posterior vaginal lesion likely has rectovaginal fistula, an aberrant connection between the rectum and the vagina. Rectovaginal fistula most often occur after the third or fourth degree perineal laceration with inadequate wound repair or wound infection and breakdown. A large perineal laceration, as in these patients, can cause abnormal healing of the rectovaginal septum because the proximity of the rectum to the vagina and the rectal mucosa may infiltrate and form a fistulous tract during healing, resulting in rectal mucosa being visible on the postervaginal wall, often appearing as dark red velvety lesion. As the fistula gradually develops over weeks to months and expands flatus and fecal material through the vagina, resulting in malodorous tan vaginal discharge. Diagnosis is typically clinical based on visualization of the postervaginal defect. For patients with unclear presentation, imaging may be performed and treatment is with surgical repair. If you look at the retained foreign body gauge can cause malodorous vaginal discharge, but it is typically seen on examination because it obstructs the visualization of the normal pelvic structure, postervaginal wall. Looks like okay. This patient's vaginal spotting and the uterine size greater than the gestational age. Uterine size greater than the gestational age more than 14 weeks at 9 weeks of gestation due to, due to complete hydatidiform mole. Complete hydatidiform mole pregnancies result from an abnormal fertilization of empty sac fertilization. Abnormal fertilization of an empty ovum either by two sperm or by one sperm subsequently duplicates its genome. These abnormal fertilization leads to trophoblastic proliferation of the hydrophic villi and not associated with fetal development. The uncontrolled molar tissue proliferation and endometrial blood collection can cause first-degree vaginal bleeding. A uterine size their discrepancy markedly elevated beta ECG level more than 1 lakh. The characteristics finding of a complete hydatidiform mole is an endometrium with a Swiss cheese or snowstorm appearance. This appearance is due to cystic hydrophic villi that can generate a heterogeneous mass with an anechoic spaces but no fetus or amniotic fluid. Additional ultrasound include Additional ultrasound finding may include theca lutein cysts, large bilateral multilocular cysts that occur due to ovarian hyperstimulation. Treatment is with suction curettage due to risk of malignant transformation and choriocarcinoma. Mm, Malignant transformation like choriocarcinoma, patients are allowed with serial monitoring until beta HCG is undetectable. Got it? Okay. We can start. You want to take a break? Okay, no problem. Okay. Is it phenytoin? Fetal hydrogen. Okay. Okay. Cleft palate, microcephaly, cardiac defect, and hypoplasia of the nail and the phalanges. This patient most likely has fetal hydantoin syndrome, due to utero in which occurs due to utero in expo which occurs due to in utero exposure to an anti-epileptic drug, phenytoin, carbamazepine, valproate. Multiple anti-epileptic have teratogenic effect due to their ability to cross the placenta, resulting in low folate level, high oxidative metabolites in the fetus. The likely combined effect result in associated cleft lip and palate, widened anterofrontally, distal phalanges hypoplasia, and cardiac anomalies, pulmonary stenosis, aortic stenosis. The associated neural tube defect and microcephaly can also result in developmental delay and poor cognitive outcomes. Therefore, to minimize the risk of congenital malformation, patients who require anti-epileptic during pregnancy should be titrated to the lowest dose for seizure control prior to conception and started on high dose 4 milligram folic acid supplementation. Okay, look at the fetal alcohol syndrome. There is microcephaly, small palpable fissure, mid-face hypoplasia, smooth philtrum and thin vermilion border, and use of lisinopril. Okay, lisinopril during pregnancy can cause fetal renal failure and oligohydramnios. That results in pulmonary hyperplasia, growth restriction, Potter sequence. Okay. Maybe none of them. Okay, postpartum urinary retention. This patient has an acute postpartum urinary retention defined as inability to void more than 6 hours after inability to void more than 6 hours after vaginal delivery, or more than 6 hours after urinary or more than 6 hours after urinary catheter removal following cesarean delivery. These patients with acute urinary retention can develop concomitant concomitant overflow incontinence, resulting in clinical features such as urine dribbling and lower abdominal pressure from an over-distended bladder. Postpartum urinary retention. Postpartum urinary retention often occurs due to the following: perineal trauma from the prolonged second stage of labor and or perineal laceration that results in pudendal nerve injury. Damage to the pudendal nerve can result in decreased voiding sensation, thereby promoting urinary retention and cause external urethral dysfunction and can cause external urethral sphincter dysfunction. Reduced sensory and motor sacral spinal cord impulses from regional neuraxial anesthesia, epidural anesthesia, which can suppress the micturition reflex and decrease testosterone. So epidural anesthesia, which can suppress the micturition reflex, decrease testosterone, resulting in bladder atony. Other risk factors include primiparity and operative vaginal delivery. Management is with intermittent urethral catheterization and reassurance, as retention is typically self-limited and resolves less than 1 week. Okay, urethral injury may result from pelvic floor surgery or perineal laceration repair from a foreign body mesh suture. Patient can have urinary retention and dribbling, however, they typically have urinary frequency dysuria and a slow, interrupted stream from the foreign body. And the vesicovaginal fistula may occur secondary to obstetric complication, prolonged labor, operative vaginal delivery, and can cause persistent urinary dribbling. However, it often take it often takes days to develop, and there is typically no associated bladder distension as urine continuously drains through the fistula. Okay, postpartum urinary retention. It may be due to primiparity, regional neuroaxial anesthesia, operative vaginal delivery, perineal injury, and cesarean delivery. Clinical feature is small volume voids or inability to void, incomplete bladder emptying, dribbling of urine. Management is self-limited condition and intermittent catheterization. Sorry. Okay, laparotomy. Okay, this box. Low transverse cesarean delivery, horizontal section. Sorry, horizontal incision. Low transverse cesarean delivery, horizontal incision. Trial of labor, contraindicated. No. Classic cesarean delivery, trial of labor, contraindicated. Yes. If there is, as this patient has abdominal myomectomy with uterine cavity entry, isn't it? She has abdominal myomectomy which uterine cavity has entered. So abdominal myomectomy with uterine cavity entry. So no trial for labor. Trial of labor contraindicated. Uh, trial. Trial of labor contraindicated. Yes. Okay. Trial of labor contraindicated. Yes. An abdominal myomectomy without uterine entry. No. So if without uterine entry, then which option will be the, sorry, maybe done, that's why it has written. Okay. Okay, the risk of uterine rupture, the risk of uterine rupture is the greatest. The risk of uterine rupture is greatest in laboring patient with prior uterine surgery, particularly a prior classic or vertical cesarean delivery or a prior myomectomy that was extensive or entered the uterine cavity during removal of the intramural or submucosal fibroid. So for intramural and submucosal fibroid, we need to enter the uterine cavity. Given this patient's myomectomy, her intense, constant abdominal pain and abnormal fetal heart sound racing, persistent variable deceleration are concerning for uterine rupture. Other possible manifestation of uterine rupture include vaginal bleeding, abdominally palpable fetal part, loss of fetal station, change in contractile pattern. The presentation of uterine rupture varies based on the extent and exact location of the rupture and the presence or the absence of regional anesthesia. Presence or absence of the regional anesthesia. Vaginal delivery is safe after a low transverse horizontal uterine incision or low transverse cesarean delivery. In contrast, patients with either classic cesarean delivery or an extensive myomectomy are delivered via cesarean delivery at 36 to 37 weeks of gestation. When these patients present in labor, urgent laparotomy and cesarean delivery was required. Further management is determined by intraoperative findings. If uterine rupture has occurred, delivery is typically through the rupture site. A uterine rupture is performed. If the uterus is unruptured, a hysterectomy is performed. Expected management for a vaginal delivery Expected management for a vaginal delivery is generally contraindicated in patients with prior classic cesarean delivery or extensive myomectomy. Okay. Yes, amnioinfusion involves the placement of an intrauterine pressure catheter for an intrauterine infusion to decrease umbilical cord compression and resolve variable deceleration. Amnioinfusion is contraindicated in patients' history of uterine surgery. Mm, Terbutaline a tocolytic management. Sorry. Oh, sorry. D. An operative vaginal delivery. An operative vaginal delivery can be used to expedite a vaginal delivery in patients with an abnormal fetal heart racing. Patient must be completed 10 centimeter dilated. Mm, yes, not that much. Mm, Transabdominal does not visualize an intrauterine pregnancy. Transvaginal. Uh, but previous beta ECG what is there in? So only one beta ECG is given, isn't it? The abdominal pendulum 3 days. Um, I think that is it PID or is it diagnostic laparoscopy? Okay, I am thinking in different direction. Um, Yes, vitals are normal. Okay. Abdominal examination show mild lower abdominal tenderness. So we need to do repeat quantitative beta ECG in 48 hours. That's why I am asking you the beta ECG level. As you have told me the diagnosis, so I understand the answer. Okay. So management of suspected ectopic pregnancy. Management of suspected ectopic pregnancy. Positive urine HCG, lower abdominal pain and or vaginal bleeding. If the patient is hemodynamically unstable, immediate surgical consultation. If the patient is hemodynamically stable, Transvaginal ultrasound. If there is any adnexal mass, treat ectopic pregnancy. If transabdominal ultrasound may show intrauterine pregnancy. If transvaginal ultrasound is non-diagnostic, serum beta ECG. If serum beta ECG is more than 3500, repeat beta ECG level and transvaginal ultrasound in 2 days. If serum beta ECG level is less than 3500, repeat beta ECG in 2 days. Okay. So this patient has vaginal bleeding. So this patient present with vaginal bleeding, positive beta ECG, has first trimester bleeding, which occurs evaluation with transvaginal ultrasound and a serum beta ECG measurement determine the pregnancy location. This patient ultrasound is non-diagnostic, no uterine pregnancy, free fluid or adnexal mass, which is expected because her quantitative beta ECG level 1000 below the threshold at which intrauterine pregnancy can be visualized by transvaginal ultrasound. That means below the discriminatory zone. Therefore, she has pregnancy of unknown location. The most common cause of pregnancy of unknown location is early gestation of normal intrauterine pregnancy. However, other potential etiologies are a completed spontaneous abortion, non-viable intrauterine pregnancy, missed abortion, and a ectopic pregnancy, all of which require further evaluation for definitive diagnosis. Because each type of pregnancy follows a characteristic beta ECG pattern, quantitative beta ECG are repeated every 48 hours. Our quantitative beta ECG levels are repeated every 48 hours. Early but variable, early but viable intrauterine pregnancy typically have more than 35 to 50% rise in beta ECG every 48 hours. Completed spontaneous abortion can cause beta ECG levels to decrease precipitously because the pregnancy has been evacuated. Ectopic and non-viable intrauterine pregnancy and embryonic gestation usually cause less than 35% rise in beta ECG due to abnormal pregnancy development. Patients typically require serial beta ECG measurement until the level reaches the discriminatory zone, at which point a repeat transvaginal ultrasound is performed. Those with abnormally rising beta ECG level require close follow-up due to rise of ectopic pregnancy. Sorry? Yes. Yes. rubella. So can we give influenza intramuscular, because intramuscular is killed as live vaccine can transfer via transplacentally. So okay, vaccines during pregnancy recommended Tdap, inactivated influenza, Tdap, inactivated influenza, and raw immunoglobulin. Indicated in high risk patient hepatitis A, B, pneumococcus, Haemophilus influenzae, meningococcus, and varicella zoster immunoglobulin. Contraindicated is HPV, MMR, live attenuated influenza, and varicella. Vaccination during pregnancy are indicated if the vaccinations during pregnancy are indicated if the vaccine has minimal risk, if significant risk exists for infection exposure, and if increased morbidity and mortality are associated with infection. Vaccines that are safe during pregnancy include immunoglobulins, anti-immunoglobulin toxoid, tetanus toxoid, inactivated vaccine, intramuscular influenza. In contrast, live attenuated vaccine, intranasal influenza are contraindicated during pregnancy due to theoretical risk of congenital infection. Pregnant women are increased risk for morbidity, pneumonia, and mortality from the influenza virus. All pregnant women without contraindication should receive seasonal influenza vaccination as soon as it becomes available. The inactivated influenza vaccine is safe during every trimester of the pregnancy and while breastfeeding. The vaccine prevents maternal influenza-related illness and provides passive neonatal immunity, and thereby decreasing the risk of influenza-related illness in newborn. Newborn. Okay. Yes. The tetanus, diphtheria, pertussis vaccine Tdap is indicated in every pregnancy, but ideally is administered at 27 to 36 weeks of gestation to allow transplacental maternal antibody transfer and facilitate neonatal immunity. Vaccination at 20 weeks of gestation result in antibody suboptimal antibody levels in the newborn, which can suboptimal antibody levels in the newborn due to due to waning maternal antibody production. And ENF varicella in pregnancy can use varicella in pregnancy can cause maternal complication, pneumonia, meningitis, encephalitis, and congenital anomalies, cicatricial lesions, cataract, chorioretinitis. Patients who are exposed to varicella but lack of evidence of varicella immunity, negative IgG antibody, no history of childhood infection, are treated with post-exposure prophylaxis. In pregnancy, post-exposure prophylaxis include varicella zoster immunoglobulin administration. The live attenuated varicella zoster vaccine is contraindicated during pregnancy. This patient has recent varicella exposure, but her testing suggests immunity positive varicella IgG antibody require no further treatment. No further treatment. Okay. Maybe. Yes, magnesium sulfate, max sulf can cause, uh, what can I say? Max sulf toxicity can happen. So we need to monitor the patient. Okay, max sulf, magnesium sulfate. Clinical feature mild nausea, vomiting, sorry, nausea, flushing, headache, hyperreflexia, moderate is areflexia, hypocalcemia, somnolence, and severe is respiratory paralysis, cardiac arrest. Stop magnesium therapy and give IV calcium gluconate bolus. Magnesium sulfate is administered to the patient with preeclampsia with severe feature to prevent and treat eclamptic seizure. To prevent and treat eclamptic seizure, magnesium acts as a calcium channel blocker on the CNS to raise the seizure threshold. However, with increasing serum level, magnesium sulfate toxicity can develop. Patient may initially present with nausea, flushing, hyperreflexia due to magnesium inhibition of the postsynaptic acetylcholine release. Neuromuscular inhibition. Further toxicity is uncommon in patients with normal renal function, but those with decreased urine output, such as these patients, are at higher risk due to decreased urinary excretion of magnesium. Therefore, magnesium toxicity can progress to cause further muscle weakness, loss of deep tendon reflex, areflexia, and respiratory depression, respiration of 10 minutes. At severely high magnesium sulfate level, patients are at risk for respiratory paralysis and cardiac arrhythmias. Because of these life-threatening risks, patients are treated with magnesium sulfate require close monitoring. Patients with signs of toxicity require serum magnesium level and immediate cessation of magnesium sulfate. In addition, patients are administered calcium gluconate, which reverses neuromuscular paralysis, stabilizes cardiac membrane, and prevents cardiac arrest. Okay. Yes. Mm, uh, Intravenous heparin infusions are used to manage an acute pulmonary embolus, which may present with dyspnea. Patients typically also, however, these patients typically also have chest pain and tachypnea rather than respiratory depression. In addition, pulmonary embolus is not associated with areflexia. Labetalol is administered. Labetalol is administered to patients with preeclampsia and severely completed blood pressure, systolic more than 160 and diastolic more than 10. This patient's blood pressure does not meet the criteria of acute therapy. Naloxone is used to reverse opioid toxicity, which can present with drowsiness and respiratory depression. However, deep tendon reflex are typically preserved, making the diagnosis less likely. Okay. Okay, I'm calling you 5 minutes later. Your sound is breaking. Yes, I'm calling you. Okay. Yes. Yes. Fetal heart rate is low. Is it IUGR, intrauterine fetal growth retardation? Fetal weight is 50%. Oh, no, no. Sorry. Vasa. Oh, yes. Okay, I got the answer. Yes, Vasa previous always C-section. Okay. Fetal vessel overlying the cervix. Vasa previous fetal vessel overlying the cervix. Risk factor is placenta previa, multiple gestation, in vitro fertilization, accentuated placental lobe. Clinical presentation: painless vaginal bleeding with a range of motion or contraction. Fetal heart rate abnormalities, bradycardia, sinusoidal pattern. Fetal exsanguination and demise, emergency cesarean section. Normal fetal vessel travel in the umbilical cord surrounded by thick gelatinous water jelly that protects them. In contrast, vasa previa is aberrant condition in which fetal vessel overlie the cervix, surrounded by surrounded only by thin fetal membrane, making them prone to tear with rupture of the membrane or contraction. Risk factor include in vitro fertilization as in this patient and placenta previa. Vasa previa is typically diagnosed on fetal anatomy ultrasound 18 to 20 weeks, managed with planned caesarean delivery at 34 to 35 weeks of gestation, prior spontaneous labor. Because total fetal blood volume total fetal blood volume is low, approximately 250 ml or a cup, even minimal bleeding can lead to exsanguination and fetal demise. Therefore, these patients require third trimester inpatient management to monitor acute changes that require immediate delivery. On this patient with vasa previa, the rupture of the membrane likely has ruptured fetal vessel, as evidenced by leakage of blood-tinged vaginal fluid and fetal bradycardia. The obstetric emergency requires immediate delivery because vaginal delivery can cause further fetal blood vessel tearing and continuous of So this patient with vasa previa and rupture of the membrane likely has a ruptured fetal vessel as evidenced by the leakage of blood tinged of vaginal fluid and fetal bradycardia. These obstetric emergency requires immediate delivery because vaginal delivery can cause further fetal vessel tearing and fetal compromise. Induction of labor is contraindicated. Therefore, best next step is emergency cesarean delivery. Okay. Okay, recreational drug use during pregnancy, risk factor adolescent, pregnancy late or intermittent prenatal care, adolescent pregnancy late or intermittent or prenatal care, and insufficient gestational weight gain, obstetric complications, spontaneous abortion, preterm birth, preeclampsia, abruptio placentae, fetal growth restriction, and intrauterine fetal demise. So recreational drug use during pregnancy is common. A risk factor include adolescent pregnancy, late or intermittent prenatal care, and insufficient pregnancy weight gain. Because recreational drug use in pregnancy are associated with increased risk of obstetric complication and or a long-term fetal complication, cognitive delay, all patients require screening at the initial prenatal visit. This patient has vaginal bleeding. This has this patient has vaginal bleeding and a cold cervix and a viable fetus on ultrasound. A presentation consistent with threatened abortion. Urine drug testing reveals amphetamine use. Amphetamine cross the placenta, which produce both alpha adrenergic and beta adrenergic effects. Leads to alpha adrenergic stimulation leads to vasoconstriction and increased vascular resistance in the fetal vessel, which may explain why amphetamine use is sorry. Okay. Amphetamine crosses the placenta and produces both alpha adrenergic and beta adrenergic effect. Alpha adrenergic stimulates leads to vasoconstriction and increased vascular resistance in placental vessel, which may explain why amphetamine are associated with increased risk of spontaneous abortion, preeclampsia, abruptio placentae, fetal growth restriction, preterm delivery, and intrauterine fetal demise. Tobacco and cocaine use in pregnancy share these complications, likely has similar mechanism. Next. Isn't it BP is higher for these 34 weeks of gestation, 160 over 100? Mm, Okay, this patient with vaginal bleeding and a tender firm uterus after rupture of the membrane most likely has abruptio placentae, placental abruption in the premature placental separation from the uterine wall prior to the delivery. It can occur following an uncontrolled gush of amniotic fluid, particularly in patients with uterine overdistension twin uterine overdistension mm, twin gestation polyhydramnios because of sudden loss of volume due to rapid uterine decompression. The rapid decompression causes shearing. The rapid decompression causes shearing of maternal decidual vessels and bleeding at the decidual placental interface, which leads to increased intrauterine pressure, tender, firm uterus, abdominal pain, and vaginal bleeding. Other risk factors include maternal hypertension, abdominal trauma, tobacco use. Some features of abruptio placenta are self-limited and clinically significant. However, a large population can impair fetal perfusion, fetal hypoxia, and increase the risk of fetal demise, as evidenced by fetal heart rate tracing abnormalities, bradycardia, minimal variability. Potential maternal complications include hemorrhage, DIC. Therefore, acute abruption with active bleeding and evidence of fetal hypoxia requires emergent delivery. Yes, uterine rupture, a full thickness disruption of the uterine wall may present in laboring patients with prior cesarean delivery and causes abdominal pain, vaginal bleeding, and fetal heart rate tracing abnormalities. However, patients classically have palpable fetal parts of abdominal examination and a uterus with decreasing rigidity and contraction due to decreased intrauterine pressure. Okay. Is it cluster headache? Is it postpartum like anesthetic headache? Like postpartum preeclampsia? What we do? CT So this patient, this postpartum patient with worsening headache and severe hypertension, this postpartum patient with worsening headache and severe hypertension has a preeclampsia with severe feature which can present up to 6 weeks after a delivery. The most common presenting symptom is severe headache in the bilateral occipital and frontal bilateral occipital and frontal region that does not improve with acetaminophen and NSAID. Patients with preeclampsia are increased risk of hemorrhagic or ischemic stroke due to acute elevation in the cerebral acute elevation in the cerebral perfusion pressure and vessel rupture hemorrhagic as well as preeclampsia mediated vascular endothelial damage microthrombi formation to decrease the risk. Preeclampsia patient with severe range blood pressure require aggressive antihypertensive therapy, labetalol, nifedipine, magnesium sulfate, which can help prevent eclamptic seizure that can worsen stroke symptoms. More preeclamptic patients do not require imaging. However, in those with focal neurological deficits, such as this patient asymmetric motor deficit, um, strength right more than the left, and CT scan of the chest should be performed to evaluate for possible stroke and help guide management. Okay, okay, box. Okay, yes, okay. Preeclampsia risk factor nulliparity, obesity, pre-existing medical condition, SLE, chronic hypertension, multiple gestation, advanced maternal age. Definition is the onset hypertension, systolic blood pressure more than 140 and diastolic more than 90 after 20 weeks with proteinuria with or without organ damage. Severe feature is severe range of hypertension, systolic blood pressure more than 160 and diastolic more than 110, platelet less than 1 lakh, creatinine more than 1.1 or 2 times normal, elevated transaminase, pulmonary edema, vision or cerebral symptoms. Management less than 37 weeks and no severe feature is expected. More than 37 weeks is delivery. Severe range of blood pressure, IV labetalol, IV hydralazine, paroral, nifedipine, and seizure prophylaxis, magnesium sulfate. So less than 37, no severe feature is expected. More than 37 weeks or 34 weeks with severe feature, delivery, and severe range of blood pressure, hydralazine, paroral, nifedipine, and seizure prophylaxis. Okay. Okay. Have you done your breakfast? Okay. Yes. My sister is calling. That's why I need to take a break.